immunoglobulin was marked in states. So when you use the FAFAS protocol, you can pass immunoglobulin day and night. But when you use the IVL protocol, you cannot use the osaparinib in this trial. So the more alternatives, the more difficult the choice. The information submerge the truth. So we need to know the key issue, and we need to have the consistency. How can we do that? So we need to find some key to run through all trials, and all trials is important for everyone for our care patients. So I would like to summarize the first line therapy for metastatic colon cancer. We need to stratify by ORAS mutation. The first issue is RAS wild types, about 40%. We difficult to find the truth, and the FASRI and the CLGB make everyone very puzzled about that. So we open this issue and request everyone to vote for this issue. So we have the result from Friday evening, and we see the result is the most doctor in Taiwan choose FAFRI up to 66%, and the FAFAS only 22%. And some doctors choose FAFAS. The second question is, which biological agent do you prefer in first line for RAS wild type patient? Most doctors in Taiwan choose cetuximab, nearly 70%. And best regimen, most doctors choose cetuximab with FAFRI. But actually, back to our clinical practice, beva and cetuximab is half and half. It's very needy, but I don't know the reason why. But the best one is cetuximab plus FAFRI. But when we face a patient, we just choose the beva and the cetuximab is equal. And when we need to take care of yourself, most doctors also choose the cetuximab plus FAFRI. Also, let me summarize the first line therapy for RAS wild type patients. Most doctors favor FAFRI is better than FAFAX as backbone, and the cetuximab is greater than bevacizumab. When we use the patient, ask the doctor want to choose all drugs, so cetuximab is equal to bevacizumab. Okay. Beyond FASRI and the CLGB, what is the optimal arrangement? Do we have more? Of course, we can see some new trial to show. Of course, the answer is yes. We have new choice, like for FASRI, plus the beva. You can see the phase 3 trial use of FASRI plus beva versus FASRI with beva. The overall response in experimental arm is higher up to 65%, and achieves a significant in progression-free survival, and overall survives up to 31 months in experimental arm. Another issue is in the RAS mutant patients. Some scholar doubts the patient with RAS mutation can get benefit with beva, but you can see the pharmacist and plus beva achieves very high overall survival up to 28 months. Trial initial treatment with FOLFIRI and beva for metastatic, we can see the wild type patient can achieve up to 41 months, and the RAS mutant patient can achieve to 28 months, and the BRAF patient is also can also achieve very high result. So I'd like to summarize first-line optimized treatment. Of course, we need to do RAS at first and BRAF at first, and the chemotherapy backbone does matter. In Taiwan, we need to always use the irinotecan as the first-line chemotherapy backbone. We avoid to use the oxaliplatin even in KRAS mutant patients. And FOLFIRI plus beva achieves the best overall survival up to 31 months and 41 months in RAS wild type patients. CLGB equal to FOLFIRI because CLGB uses FOLFOX backbone as major, and the data supports anti-EGFR is greater than anti-VEGFR for RAS wild type patients. Data support beva in RAS mutant. Of course, I think TRIBE and FOLFIRI and TMN can show the benefit from bevacizumab's use. So the treatment strategy for patients with metastasis for first line, we can use the strategy as RAS mutant. RAS mutant patient use the FOLFIRI plus beva, TRIBE's data, and FOLFIRI for RAS wild type like cetuximab plus FOLFIRI, and the BRAF patient use the beva plus FOLFIRI. After first line, when patient with PD, we use a second line and achieves good response, we use the maintenance therapy. So, but we know the first line can achieve high response and good progression-free survival in first line. But compared with breast cancer or other cancer like lung cancer, the second line is still not good enough. It's very low response rate, about majority about 5%, and the progression-free survival is very short, about 5 months. So conclusion for first line therapy is still a critical determinant of overall survival, but we need more powerful bullet for second line therapy. What choice do we have in second line? Of course, in the past, we changed to another backbone and another biologic therapy. But actually, we can use the cultural plate, like FOLFIRI plus another biologic is a dream agent. And what choices do we have in maintenance therapy? In the past, we cannot just stop and see because most patients are progressing very soon. So we need more convenient and more safe drugs for our patients. So beva and the capecitabine is available, and another average combined beva and capecitabine like TIO3 data, and possible we can use more active agents like beva plus valerian. And the savage treatment, we have the correct study. In the past, I used to say correct study is absolutely wrong because the response rate is very low, and just achieves 1.4 months survival benefit. But progression-free survival just very short, but can achieve very significant. It's quite difficult to understand. But this year, we can another try confirm the correct try show the payment is useful for our savage setting. We can see a lot of drugs, this kind of drugs, like VEGFR, TKI in colorectal cancer. In Taiwan, we can have the regorafenib and Sutent and sorafenib and azacitidine and pazopanib. but a lot of trial fail. Only Rego survive this issue. So regulatory is quite important for us to care our patients. When we use the Rego, the problem is the Henderson syndrome, but it's not a big issue. But the most important is the financial persistence is most important. So I like to use the chemosteroid plus low-dose multiple kinase, multiple targeted TKI for my patients. I'd like to show one patient, 60 years old, with KRAS mutant patient with a sigmoid colorectal cancer with microliver metastatic diagnosis in 2011. She accepted a lot of chemotherapy line like FOLFIRI, FOLFOX, and FOLFOX3. All fail about this kind of regimen. And very high CEA when we use the Excipient 2014, and plus the chemotherapy like Inotic can achieve very good response. CEA from 8,000 down to 2,900. Okay, so we use a good drug, good regimen for good combination and good biologic therapy for right patient, and use maintain and salvage care, then make our patient can easy to achieve 40 months. Okay, that's it. Thank you very much.
Now we will move to the next talk. The speaker will be Dr. Paul Yuchen. Dr. Paul is currently the staff at the Department of Radiation Oncology, China Medical University Hospital, and also the Department of Biomedical Imaging and Radiology Science in China Medical University. Let's welcome Dr. Paul.
Thanks to everyone. It's my honor to be here to present my topic. So my topic is the concurrent chemoradiotherapy in rectal cancer, 1.5. And as a radiation oncologist, I'd like to discuss and work with rich experts from different fields for the same purpose. And the combined modality therapy in cancer treatment becomes more and more important. And then now, because of you can see this, such as in the locally advanced rectal cancer, you can see that before the surgery, we can see the tumor in the PET scan here, and the tumor size is very big, and the stage is very locally advanced. But after the pre-operative chemoradiotherapy, we can see that the tumor size shrinks and the stage is reduced, and which can maybe have the potential for the surgeon to preserve the sphincter or improve the local control, decrease the distant metastasis, and improve the overall survival. But the choice is that, or maybe the choice is the opposite. Maybe we can see the next. Okay. Why the chemoradiotherapy is before surgery or after surgery is very important, because we know that the locally advanced rectal cancer, such as the T3 or T4, the patient have the high distant metastasis rate or high locally recurrent rates. And the rule of the neoadjuvant chemoradiotherapy have the potential for the surgeon to preserve the sphincter, to improve the local control rate, or to improve the overall survival rate. And for this purpose, we know that we want to know is this true or false, and we can compare the pre-operative versus the post-operative chemoradiotherapy. And there were 3 trials from 1993 to 1994, and to discuss this topic. And then the 3 trials, the first is the RTOG 9401, and the second trial, the NSABP R03, and the third one is we call it the German study. But the RTOG is the first trial closed earlier because of the small sample size. And the second trial, NSABP R03, by terminate because of the patient number is not enough because the goal of the study are the 900 patients, but the study actually collect the 263 patients, and each follow up for 8 years. And through the result, we can show that the preoperative chemoradiotherapy as compared to the postoperative chemoradiotherapy can improve the better disease-free survival, and there is a trend to improve the overall survival, even though the p-value is not reached a significant difference. But there was no difference in the local control, and the result is published in the JCO in 2009. You can see that this is the disease-free survival, and this is an overall survival, and this figure is the distant recurrence or the local recurrence, and you can see that the disease-free survival is better in the preoperative chemoradiotherapy. And this is the better too, but the p-value is not reached is a significant difference. And how about the German study? This is a German study, and we know that it was published in the New England Journal of Medicine in 2004. And we can see that preoperative chemoradiotherapy can have the local control rate as compared to the postoperative chemoradiotherapy. And besides, the preoperative chemoradiotherapy can improve the sphincter preserve the rate. If a surgeon think before surgery think that the sphincter cannot be preserved, the preserve rate will be higher. And because of the promising result, how about the toxicity? This is a acute toxicity grade 3 to grade 4. This is a long-term toxicity grade 3 to grade 4. Preoperative chemoradiotherapy group is also better than the postoperative chemoradiotherapy. And as a result of this result can be continued to the 2012. The result was published in the JCO. The result is all the same. Okay. So because of the German study, many doctors in many countries will treat a patient with locally advanced renal cancer by neoadjuvant chemoradiotherapy according to this study. So this is very important. And how about the role of chemotherapy in the combined modality treatment? And through this study and published in the New England Journal of Medicine in 2006, you can see that the result of the chemoradiotherapy before surgery or after surgery or combined with the radiation therapy is better than the radiation treatment alone, and in the local control rate. So the chemotherapy is very important in the combined modality therapy. Okay, so yes. The question, many people raised another question is that, do we overtreat a patient with locally advanced renal cancer? It's okay. And so to answer this question, so some people from America, they collect many hospital institutes such as the Memorial Sloan Kettering and the Anderson Cancer Center, and they collect the people to investigate the result. And the result says that before the people after surgery, they see the people is a clinical T3N0 patient. Also, there are 22% patients had the YP lymph positive. It seems that the accuracy of preoperative ultrasound or MRI image is limited. Okay, and so they emphasize on that the patient with a clinical T3N0 patient it should continue to receive the preoperative chemotherapy, because if you don't do that, maybe some people will undertreat the undertreat the disease. Okay, this is an Italian study. The result shows the same result. There are 28% the patient with clinical T3 and 0 patient has to have the pathological positive lymph node metastasis. So the preoperative chemoradiotherapy is very important. Okay. And how about the induction chemotherapy in this group? And some people want to know the rule of induction chemotherapy because they suspect that the people with locally advanced rectal cancer may have the early microscopic metastasis. But if you do not receive the systemic chemotherapy, maybe the patient will result in the distant metastasis. So some small study groups will try to investigate the result. And even though that the result is promising, however, the sample size is too small, and some of the studies have shown the poor prognosis, such as the complication or the distant metastasis rate. So this outcome is promising, but the result is not a conclusion. Okay, this is a prospective trial, and to try to modify the protocol, and they give the patient 6 cycles of 4 before chemoradiotherapy, and they restage the patient. If the response rate higher than 22%, the patient will receive the surgery immediately. However, if the response is lower than the 20%, the patient will receive the chemoradiotherapy and then they receive the surgery. And the third group is the chemoradiotherapy and then receive the surgery. And this result is investigating, and we can expect the result in the future. And the other side, there are 2 randomized trials here, and we can expect maybe in the next year or after 2 years. Okay. And before the result of the prospective trial, we can see the small size trial. It is published in this year in the JCO, and this is also we can give the patient 4 course plus the bevacizumab for 4 cycles and 4 course alone for 2 cycles, and stage the patient. If the disease progression, the patient will receive the chemoradiation and then receive the surgery. If the clinical response is good or the partial stable disease, the people will receive the total receive the surgery immediately. And you can see the early resection rate is 100%. And 2 of the patients do not finish the neoadjuvant chemotherapy because of the toxicity. And these 2 patients received the preoperative chemoradiotherapy. And you can see that the 4 years disease-free survival and the 4 years overall survival rate is promising. And so maybe in the future, this is a trend for us to investigate which people is suitable for the neoadjuvant chemoradiotherapy. And the preoperative chemotherapy, we call it induction chemotherapy. The purpose is to decrease the early micrometastasis disease of the downstage in the primary tumor. However, the disadvantages include the toxicity and the risk of the radio-resistant patient, or maybe, and the other is the induction chemo. The result of induction chemotherapy shows not a good benefit in the lung cancer and in head cancer. But however, in the rectal cancer, we don't know yet. Maybe we can see the result in the future. And here is some of the induction chemotherapy studies in the rectal cancer. You can see the EXPERT study and the EXPERT plus the cetuximab study, and can increase the pathological complete response rate and early resection. However, the cetuximab will increase the toxicity, so we have to focus on the toxicity of the targeted therapy when we combine combined in the treatment. Okay. But the study is the small sample size, so the study result is limited. So maybe we can see the future phase 3 trial, these 2 trials. We can see in the future. Okay. And then we talk about the pre-op. Okay. This is if we give the patient neoadjuvant chemoradiotherapy and then prescribe the chemotherapy before surgery. Okay, this topic has a strong argument because maybe the preoperative chemotherapy will impact the effect of the chemotherapy. So this is very, we have to, if we want to do that, we have to think about the disadvantage. And you can see there are some studies to investigate this result. And this is a Dutch study in the Netherlands. They used the short course of radiation therapy, 5 grams per day for 5 days. And then they immediately give the patient capecitabine plus the oxaliplatin, the bevacizumab, and for up to 18 weeks. And you can see the result is also promising. And this is another study that shows that after chemoradiotherapy, if we prescribe the 2 cycles of 5U, we can increase the pathologic complete response rate from 80% to 25%. And if we add the two more cycles, we can increase the 25% into 30%. So maybe it's also another choice for us for patient to treat the patient. Okay. And how about the long course chemoradiotherapy and the short course chemoradiotherapy? We can see this is also argued from Asia and Europe. And I have no experience in the short course radiotherapy, so I cannot share my experience with you. And we can see the guideline this year in the Europe. They agree the long course chemoradiotherapy and the short course radiotherapy in the locally advanced renal cancer because of the both regimen improve the local control and have the similar overall survival and the lack toxicity. So the advantages of the short course radiotherapy are less acute toxicity and less cost. The advantage of the locally advanced radiation chemoradiotherapy is for tumor shrinkage and the downstaging and the pathologic complete response rate can be reached up to 36%. And if you use the short course radiation therapy, you can also expect the same downsize or downstaging or even pathologic complete response rate if you delay the time of surgery. Maybe you can see the same result. Okay. This is the NSFEPR04 study. They try to investigate the different chemotherapy regimen between 5U and capecitabine. And so they divide the patient into 4 groups. The group 1 is 5U, the group 2 is 5U plus the oxaliplatin. Group 3 is the Xeloda, and the group 4 is Xeloda plus oxaliplatin. Okay. This result shows that no significant difference between 5U and the capecitabine in the local control rate and the overall survival rate. However, if you add the oxaliplatin into the regimen, maybe you could increase the grade 3 or grade 4 toxicity. So this is very important. If you try to do that, please emphasize here. Okay. So the summary of the SFEPR04 is capecitabine with preoperative radiation therapy achieved a similar result to the 5U2 and the PCR rate, local recurrence rate, disease-free survival rate, and the overall survival rate. The 18 oxaliplatin did not improve the surgical outcome, but added the significant toxicity. So capecitabine could be a standard choice in the preoperative chemoradiotherapy. Okay. And the other issue is the importance of imaging. Now we routinely use the MRI to stage the patient before treatment. But the limited of the T2 where the MRI is the understage the patient. So this paper in the British Journal of Radiology, they concluded that you can add the PWI image into the T2 way. If the MRI image maybe can increase the accuracy. For example, this is the tumor before chemoradiotherapy. And after chemoradiotherapy, you can see the tumor shrink. And however, if you use the DWI, maybe you can see a small residual tumor here. And then combine the figure B and the figure C into the figure D, you can see there is a residual tumor here, but you cannot see anything in the PET scan. So if you want to use the MRI image, maybe you can consider the DWI. Okay, and as I talked, this is a combined modality, so we have to combine surgeon, radiation oncologist, and the medical oncologist. This is our group, team group. And here I'm happy to show the preliminary result of our experience in here. But I have to say that this result is preliminary because of the smaller patient size and just only 5 years experience. So if I have a chance, I wish I can share 10 years or 15 years result in the future here. Okay, in our hospital, we collect 160 patients, and the tumor location is here, and this is a tumor regimen here. And before, I remember that from the first year and the 2 years, we used the 5U or the 4 folks to treat the patient. But now, in these 2 years, we changed the regimen to the Gelota. So now, most of the patients will receive the Gelota and combine with the radiation therapy. This is a surgical procedure. The same you can see. Now, more than 2/3 of patients, we use the laparoscopic surgery to treat the patient, and this is the open surgery. The robotic surgery is the number of the patient received the robotic surgery is increasing in these 2 years. Okay, and the median duration from the chemoradiotherapy to surgery is 8 weeks. And we can see the PCR rate in our hospital is 11.45%, and compared with the German study is 8%. And annual preservation rate is 77%, and the German study is 69%. And this is the T2, T3, and the T4 that we can see more patients T3 patients. There is no difference between different surgical types we compare with the laparoscope and the open surgery. And from the gender, age, clinical T stage, clinical S stage, no clinical difference. In the overall survival, it's similar. And disease, cancer-specific survival similar. And pelvic progression-free survival similar. No difference. And the distant metastasis, no difference. And we can see here the pelvic recurrence rate, YPT stage, PCR rate, and the blood loss. These 4 factors in the laparoscopic surgery is better than open surgery. But maybe there is some bias for the surgeon to select the patient. So maybe the patient here is more advanced for patient is too advanced to receive the laparoscope. So this is a bias in the result. And this is the anal-preserved location. We divide the patient from the low anal, middle anal, the upper anal. And you can see for the patient, the tumor location in the upper anal, we can preserve the patient to the 100%. And the low, if we focus on the lower rectal cancer, we have reached almost 60% for the patient, and this is the tumor location. And the average tumor location is 3.48 from anal verge. Okay, we divide the patient to see the PCR rate. And we focus on the low cervical cancer in our hospital. We have preserved the anesthesia. There are 36 patients, and the 27 patients received the laparoscope, and the 9 patients received the open surgery. The same. There are no significant difference between the laparoscope and the open surgery in the pelvic recurrence rate, distant metastasis, or overall survival rate. So, in conclusion, our experience in these 5 years, we reached the PCR rate to the 11.45%. Annual preservation rate is 77%. And local laparoscopic surgery have better results than open surgery in the pelvic recurrence and the YBT1, PCR rate, and blood loss. Okay, thank you very much.
Thank you, Dr. Go. As the next speaker will be Dr. Chen Dehong. Dr. Chen currently is the attending physician of Department of Surgery in China.